if you count and you're one off, you're like, I just have to do it again. And you did, and sometimes we would get that right number. So that made a big difference too in having that capability in front of us. But it was all just manual count.
Without supplies, there's no surgery. Without products, there's no patient care. Welcome to Power Supply, the healthcare supply chain podcast focused on helping you navigate the intricacies of logistics, purchasing, contracting, and supplier relationships. Each episode, we speak with healthcare executives, supply chain leaders, and innovative entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the loading dock to strategic sourcing, from buyers to the C-suite, and across the enterprise, we tackle the real-life issues impacting the healthcare supply chain. Whether you're tuning in for conversation or inspiration, we're glad you're here. You're just in time to hear it from the source and stock up on insight. So sit back and plug into Power Supply.
Today on Power Supply, we will speak with Kimberly Alexander, Director of Materials and Purchasing at Huggins Hospital. We're going to be talking about how to prepare for annual inventory, but in the context of a critical access facility. So, Gary, Kimberly's been there for just a short while. She has a very interesting background that she's going to tell us all about as we kick off the interview in a few minutes. But excited because I've known Kimberly for a while, and she's got such a dynamic personality.
No, it's great you brought her on the show. Looking forward to seeing what Kimberly has to say, especially in the rural setting. Whether you're $100,000 in spend annually or $1.2 billion in spend annually, I think we can always learn what's working well in preparation for our annual physical inventory. We all have to go do it. We all have to balance the books. We hope, then pray that we're within the thresholds at the end of the year that we can report to our CFOs and to the team. So I'm really curious to see what Kimberly has to say today in that setting, and hopefully we can learn some best practices. So thanks for getting on the show, Justin. Looking forward to Hayes, you and I having a conversation today.
All right, everybody, stay with us. Up next, Kimberly Alexander after a short break.
Bam! I'm Hayes Walder.
This is Gary Skinner.
And I'm Justin Poulin.
From the studios of Healthcare HQ, you're listening to Power Supply.
Today we have the pleasure of speaking with Kimberly Alexander, Director of Materials and Purchasing at Huggins Hospital. Kimberly, I've known you for quite a while and had the pleasure of seeing you. We didn't even get a chance to talk, but I saw you at the Regional ARM event, Nesham's annual conference just a week ago. And so, great conference. Wish we had a little bit more time to spend together, but I get to make up for it by having you on the podcast today. So thanks for coming on.
Of course, you're welcome. I know I'm so sorry I missed you as well.
Well, it's my bad. I'm always on phone calls. As Hayes and Gary know, I've got a hard stop.
Or that's just go-to.
It is his go-to. I got
his license plate.
I tell him I have a hard stop even when I don't have one because I'm done talking to him. Wow. Too bad we don't have video for this episode. That's too good.
This is really
all
good.
Right. We're going to be talking about preparing for annual inventory, best practices and critical access. And Kimberly, as you can tell, we have a lot of fun here, so feel free to pick on us as well throughout the interview. Why don't you just give everybody your background? You've got an interesting background of how you find yourself in your role today.
Sure, of course. I started my career, I have my master's degree in counseling psychology, so I started working with chronic mentally ill adults in Center City, Philadelphia, and then realized that what I wanted to do, I needed a PhD to do it. So I transitioned into marketing with IBM and started from there into sales, and then transitioned to pharmaceutical sales. And from there, transitioned to device sales. And that's where I landed in the hospital world. So I worked for a rural community hospital in 2014. And I ended up going back and getting my MBA over the next 5 years. So I felt like that, even though I had my master's, really could benefit from an MBA. And I started as a contract manager, moved to the director. So I was at that hospital for over 10 years. And then it's just been 5 months that I've been here at this awesome critical access hospital.
What a journey that is, and kind of a cool, windy path you took. But I'm sure that makes you, you have a whole new perspective and view of what you do now.
Absolutely. Yeah, just coming from the vendor side and then coming into the hospital. Never thought that I would do it. And then once I was there, never said I wanted to go back. So it's been a great journey.
There's been a few that have taken that path. Susie Collins took that path. Gary, you took that path, right?
Yeah, I did even the pharma deal.
But see,
I did the same thing.
Oh, wow.
Neuroscience, deep into neuroscience meds, learned a lot about Hayes and dealing with his social issues, but we work with him. We love him. We care about him, but it's studying of people. I study Hayes a lot.
But I mean, my understanding was, Kimberly kept on getting promoted and moving up. You kept on getting fired and moved down. And so that's the reason you have so many jobs. I'm just saying, is that correct?
Hayes, you're absolutely correct, and you fail forward. If you can look up, you can get up. That's all I got to say, bro.
Okay, Zig Ziglar.
Good one.
Les Brown, baby. Les Brown.
Well, Kimberly, let's talk about critical access facilities too, because that's a tough environment to be in right now. I mean, with all the changes going on, we just had an advisory group meeting for power supply recently, and we have several members from critical access facilities, and even on that pharmacy side and 340B and just a lot of the implications, it's got people a little nervous. So I wondered if you could maybe talk a little bit about what it's like to work in that critical access environment and maybe some of the unique pressures for your facility and others alike like it.
Sure. I think those that you just mentioned, and you're right, it's definitely different. I think we are fortunate enough right now to be independent and have a plan to remain that way, at least for the near future. What's different really is that in supply chain, it's not just you have one position. Everyone's position is really across the spectrum, and you really have to know about what everyone is doing, because at one point or another you're going to be filling in. We have 5 people in my department right now, so inevitably one is out, then someone needs to either take over some buying, the receiving, the delivery of inventory, and I think that we haven't felt those challenges, but just knowing that the importance of cost saving measures and reducing our expenses, that's top of our list.
Well, you just mentioned inventory, and that's what we're here to talk about today. Annual inventory. What a party, right? Everybody is just like, oh, this is my favorite time of year. Tell us why.
Yeah, well, and it's been several years since I've had to do it. In the other hospital I worked, we stopped doing it about 3 years ago. So getting back into it was a little bit of a learning curve for me. And it's one of those daunting things that everybody takes a part in, and you're counting every single item. And one of the things when I started in June, and our fiscal year ends September 30th, is that I wanted us to do some cycle counts. So we are not sitting there at the day of inventory and finding that we had so many discrepancies. So that was a goal of ours, and we were able to successfully go through everything before that September 30th date. And we had to enlist some help on that day and got it from our AP team, which meant that we did not have overtime this year like we always did in the past.
Kimberly, I love the fact that you implemented cycle counts in preparation for it to save yourself some time. Can you give us a little more detail? I remember the days of Meditech. I don't remember if it was Magic and it was ABCs and count how many times a week. Can you give us a little more detail on your cycle counting in preparation for this for our users? I'd love to hear a little bit more.
Sure. I didn't do the work myself. I really leaned on my team to help develop the process. So we have about 18 rows of inventory here, and one of our purchasing agents, and along with our procurement systems analyst, went through and just simply divided it amongst 5 of us. So each of us have about 150 items, and it was a way for us to just be able to kind of spread it out equally, because as you know, some of those rows have the teeny tiny supplies that take forever, and then the other rows have some bigger supplies that aren't as time consuming. So it was a nice way for us to just divide and conquer, and everyone had a hand in it.
I want to see it. I want to visualize it. We have clipboards? or do we have workstation on wheels? Do we have handheld scanners?
It
Tell me a
was
little bit.
so it was workstation on wheels. There's no scanners down here in our supply area. So the only thing you had on the workstation was your laptop. Spreadsheets were made custom for each of us. So we knew exactly what on the spreadsheet, what we were supposed to have, and then counting. And that was a big deal because even for myself, when we did the inventory, and if you count and you're one off, you're like, I just have to do it again. And you did, and sometimes we would get that right number. So that made a big difference too in having that capability in front of us. But it was all just manual count.
Yeah. So Kimberly, you started 5 months ago and there was nobody in your position before you. This position was created, right? So what was kind of like the baseline for inventory management before you got there?
Yeah, so,
or was there such a thing?
Yeah, there was. And so
Okay.
there was a materials manager, just there wasn't a director. So there was someone, but they hadn't been in the hospital since September of 24. So it had been a decent period of time without someone. But I think in the past, cycle counts were not a regular thing. And inventory was historically pretty far off. And, ranging from, I think the average over the 5 years of 2020 to 2024 was about a 42% discrepancy rate. And yeah, and the value of that averaged probably somewhere around 15 to 20,000. So percentage wise, the best year was in 2020 and it was 7.5% off the value.
And I know those numbers seem small, but in a rural hospital, public health hospital district, that critical access, those numbers are huge, right? Those are
Yeah,
huge.
because our total value this year at least is about 158,000.
There we go.
So, what was your goals? Like, I know we're kind of like treating this as a little bit of a case study in process improvement, and cycle counts are a big part of that. And we'll dive even a little bit deeper into maybe how you would accomplish some of this. But what was your goal, and what did you get to? And, and then maybe even where are you trying to get it to next?
Sure. So yes, when I started, because I started when I did, I still needed to have some true goals that were going to be measured over those next 3 months. And I probably was a little optimistic and said, I think we can get to less than 5% discrepancy. And I know that that's really the industry standard where you want to be. And I thought we can do this. We're doing cycle counts. We'll be able to get there. So that became part of my written goals. And I actually had to change a goal for my procurement systems analyst as well. And she got the same goal. So, and knowing everyone knew that 2026 goals, everybody was going to have that goal. So we all needed to have, a stake in this. And we reached 17% discrepancy, which I didn't think was terrible. I'm like, okay, we're better than what it had been because it was, like I said, like 42. When we took it a step further and looked, how many were we plus or minus one, like one each? We got down to 9%. So that made us feel like, you know what, this was a really nice accomplishment. And from a dollar value, our discrepancy was $955. So that was huge.
Yeah, you improved it. You improved it by a bigger percentage when you actually looked at dollar amounts
100%.
versus, how many were spot on or not.
That's right.
That's incredible. That's very
Does
good.
that
even change the way you look at it? Like, are you looking at it more as maybe how much you're off dollar wise moving forward versus percentage? Like, will you even change how you do the KPI?
We'll still keep it for the 5%, but I think it's just going to, when you get that low and do that other, analysis, then I think we're going to see those results. So, and then now we have, the way we've implemented the cycle counts, we're not counting everything every month. So now we'll have every quarter, each of us has to count all of us. So it's all of our, assigned rows. When we look at the 3 months. So let's say I have 150. The goal is first month of the quarter, you're doing 50 and then 50, 50. the other thing is after one full quarter, we're going to rotate. So we won't always count the same areas. Each of us, we did a, 1, 2, 3, 4, 5, and that's going to shift for every quarter, which I think will be nice because then you're not always counting the same things.
Yeah, that makes sense. And now, we talking about OR, we're talking about store, everything, correct?
No, just general storeroom.
Okay.
OR is something that's hopefully future, but not here yet.
Let's talk about some of the challenges. One of them you just alluded to. You were newer in your role. You implemented cycle counts, but you didn't have a full cycle of the cycle counts for a full calendar year. So obviously, that's going to have an impact when you do this again next year. But what were some of the other challenges that you found as you were trying to implement this and prepare for annual inventory?
Yes. So last November, there was a change to our MMIS system. And that change had some challenges in the sense that the reporting was not as simple as what I had experienced from previous MMIS systems, that the reports were all coming out as PDFs. So we have found some software to be able to convert those successfully to Excel spreadsheets. And that was a big help, but that was also that initial challenge. So I talked about how we created those spreadsheets that had the number of what should be there. That could not have been done without the use of this software because you couldn't get those numbers in an Excel document from our MMIS system.
Kimberly, supply chain going through change? No, never. Hayes, you see supply chain change all the time on your podcasts that you do. All the time.
Yes.
That's it.
It's actually what the council is all about, right? Is evaluating change and collaboration and technology and connecting folks like Kimberly to, the
industry.
Absolutely.
Industry so that they're tailoring their solutions around those needs.
Yeah. We even, I've heard several of your podcasts with the AI, and we had this hope that ChatGPT, because somebody told us it would work, we could throw that PDF report into ChatGPT and it would create this beautiful Excel spreadsheet, but it's way too complex to be able to do that. So AI did not help us.
Yeah, I feel like AI isn't quite ready to do Microsoft product documents quite yet. You'll see them out there and they'll be like, oh yeah, I can create a PowerPoint for you, but they're just not quite there yet. What about inventory controls? Was that another challenge for you? It's just making sure,
yes.
How did you control the inventory?
So that is a challenge, and that's something I haven't seen here. So we do not have a locked area for our inventory. And it is a clear honor system when people come down here and take things that they need to be signing them out. And if they do not, then we don't have accurate numbers. And when we don't have accurate numbers, sometimes products don't get ordered because we have that auto ordering that when we reach that minimum reorder point, it will auto order for us. It's not going to happen if it thinks we have 10 on the shelf when we only have 2. So or I should say we only have 2 on the shelf and it thinks we have 10, opposite of what I just said. So it is definitely a challenge. I think years ago, there was an attempt to lock the area, but we share it with facilities. So see, that's another thing about a small hospital. You don't always just have your own space. You have to have roommates. So, which, we love that they're here. It makes it really difficult to lock it. And biomed's here as well, too.
Everybody joins in there.
Exactly.
Free space.
Yeah. And we've made some strides with minimizing the amount of time that people are coming down here, especially the ED. And the leadership in the ED has been supportive. Our first inventory staff member comes in at 3 a.m. even before 3 a.m. on Monday morning. So, our message to them is if on Sunday you're feeling like you can't get through until 3 a.m., please don't do it, because then it becomes very manual for them to sign something out. Then we have to manually put it into our MIS system to decrement it from the inventory.
And I think you bring up a point that our listeners need to hear that they may not be aware of, but you don't have 24/7 control in your weekends. Probably have a checkout policy that you may want to share a little bit of how that works and how you come in Monday to clean that up. on your inventory, because it all has downstream effect, correct, Kimberly?
You're right. Great point, Gary. Yes, I've never worked in a hospital we had 24/7. So we leave by 5 p.m. Monday through Friday. No staff is available on the weekends. So it's those times that we say, of course, you can come down. Typically, the nurse supervisors are the ones that come and take product. And we just hope and trust them that they are going to sign out what they are taking and it's going to be accurate. We've changed that sign out sheet to have, please print your name, please put your phone extension for those that we can't read. And it's getting better. It's still a challenge though.
So you might have mentioned this earlier, Kimberly. Obviously, it's critical access, but roughly how many beds do you have? What kind of census that you might expect on a daily basis?
Yeah, critical access is no more than 25 beds.
Right.
Well, so here's my curiosity is the seasonality, just because not every critical access facility is located in the middle of summer vacation land. And, you're right by Lake Winnipesaukee in New Hampshire. So, maybe not everybody's been there, but they must have read a book that referenced Lake Winnipesaukee at some point in their life. And so I just wonder, how much does your census vary from the winter to the summer months, and how do you manage inventory that way as well?
So that was one of my interview questions that I asked before I took this position, because I'm definitely curious. And apparently prior to 2020 and probably even 2021, it was very seasonal. So you would see very large spikes in the summer and not so much in the winter. Since then, there have been some people who have since relocated. So now that peak is still there, but not as steep as what it used to be. So it has leveled off a bit. So from a supply standpoint, they're not significant changes that we're saying, oh, we really need to pull back on these things. I think one of the things I experienced, here is my first summer here, definitely the ED is much more busy in the summer. I don't know if that will change when we get into more of the winter season, because there are winter sports here as well. So you'll have, the skiers, snowmobilers, snowshoers, etc. So we might
wood
see
choppers.
Right.
Hey,
I mean, it can happen.
All right, well, let's talk about some best practices then. I think you kind of alluded to them in all the things that you put into place, but maybe you just run down, if there's somebody else. And, the other thing I've learned about critical access facilities, especially in remote parts of the world, like where Gary lives, is that there's just not a lot of people around. And so when there's turnover or somebody retires, is often somebody who's very new to their role that's kind of moving into it, which is part of the reason I love having a good amount of critical access and rural hospital conversations on the podcast, is I feel like that's probably who's also listening, especially if they're new to their career. So can you just kind of wrap up some succinct best practices that, hey, you got to check off these boxes to do a good job with inventory where you work?
Absolutely. So I think, the ideal, I think, is locking the inventory. That would be the most ideal. I'm not sure we can do it here, but if it is possible, because that's going to help you to improve your tracking of it, knowing that your team is the only one taking the inventory. Maybe on occasion a nurse supervisor. I think the cycle counts are key. And I think that helps to keep, if you can't control that inventory by locking the area, then having those regular quarterly cycle counts that will essentially count every single item in your inventory, then you're going to have a better handle on it when it comes time for your annual inventory. And then just, as I mentioned in the beginning, our accounts payable team, bringing them in, when at the last day of the fiscal year, they don't have much going on. Their work starts after those books close. So they volunteered to come and help us. And that was huge for us, and of course they're math whizzes too. So you could give them two numbers and they could add pretty quickly. So we found a lot of benefit in having them join us. So seeking resources from other departments, I think, is another best practice, especially for the annual inventory.
You know what? I foresee that Kimberly's going to put a Ring camera up in there and catch people coming and going on the weekends. And I'm thinking that's going to happen.
That is a good best practice.
My gosh, Hayes, you just blew my mind a little bit.
My phone, right? Yeah.
Literally every single person that walks in and out, you'll know exactly who it is.
You can just have two cameras, one in the inventory and one right at the door where they leave. And if they don't sign it out, you're watching. You switch to the other camera and you just go over the speaker and be like, please sign that out.
I would think that would be ideal. And for $200, I think it's worth it.
Hey, you really, look at that.
Seriously. I'm like losing my mind. I mean, how many clipboards are sitting outside of these critical access hospitals that don't have a solution when they come down and a nurse names it at some name, doesn't write down the SKU, can't print their name because they're in a hurry. They got to take care of patients. Let them take care of the mission. But man, Hayes, you may have came up with something that's very simple, but very implementable.
Yeah. I also think if you had the capability technology to scan those barcodes, and that would really be the easiest. And then to have that all be electronic and not have that clipboard. We're just not there yet.
Right there. Throw a wow right there at the door.
Exactly.
And it moves robotically in front of the door when they come in, and then they have to sign it, and then it moves back.
That's right.
I like it.
And it's equipped with a taser for anybody who doesn't follow the process. So, Kimberly, what's next? I mean, you're already doing a lot there. What's next? I know you got big plans. And, you're highly capable. So where are you taking this thing?
So it's bringing back value analysis. That hasn't been here for over a year. And I think that's critical. And ensuring that we have the clinical integration of value analysis. So I've created the presentation, talked it over with the CNO. So right now we're just waiting for data. And what I mean by that is the capability of us to easily run some usage reports and be able to manipulate it. Because starting value analysis without data, I think that we would fall flat. So I think that's really important. But I think we're probably a couple of months away from that ability, and then that will change everything. So we have a team lined up for who will be part of the value analysis group, and I will be ready to go.
Are you going to be leading that?
Initially, yes, that's the plan. And then eventually I will hopefully transition it to our procurement systems analyst. She'll be behind the scenes anyway in the beginning doing all of the data. So I think she's fully capable of taking it over after we get it off the ground and have a good process for it.
Is it common to have value analysis at a critical access facility?
I don't know the answer to that question. I don't know.
Gary does.
Yes.
I say yes. I think Kimberly mentioned earlier they have an OR. If it was new supplies come in, new technology comes in, it needs to be vetted from all perspectives on a clinical perspective to IT, support services, to finance, to supply chain. What's the impact? Is it on contract? Is it off contract? What does it look like? If there's a change, I think it needs to be vetted. And sometimes you start with the vendor to provide that opportunity if they want to supply it. Maybe you got a rotating locum surgeon that's coming in once a month to do procedures, and he needs something. I think we need to make sure what they get, but also there's downstream effect that needs to support it, whether you're at a giant 1.5 billion in spend or 120,000 in spend. I think you still need it. And at what levels? Obviously, you can minimize and maximize it as well.
I agree. So I don't know whether it's common, but I think that it's necessary. I agree with you, Gary.
Yes.
For being able to just, even as simple as standardization, we want to maximize our standardization within our GPO as well, and making sure that we're taking advantage of all of those programs where we can maximize our rebate potential. So a lot of that comes from value analysis.
And I think you hit the nail on the head too, the standardization. What's the ED using? What's the OR using? What's general using? What's the floors using? And all of a sudden it becomes, that's labor intensive, right? Especially for your inventory. So I think you're right on with the standardization, and then the GPO behind it to support the fiduciary responsibility. You're right on.
Sure. And I don't think that the right answer is to just select products that cost the least, because if the clinicians don't love them, but they think they don't have a choice, we want to hear from them, and we want to give them the best products at the best value.
Very good.
Yeah, that's huge. Is that why you're implementing value analysis, is to get better data too? Obviously there's a data collection and performance
I think we need
component,
it. Yeah.
Right?
You know what else we don't have right now is a savings tracker. And I think that's really important to have a tracker that's going to really have one place to go for all of our savings, not just value analysis. We have the rebates, everything in one place. And that's going to show the C-suite what we're doing and the value that we're bringing to the hospital.
Right.
That's
on,
so
Kimberly.
huge. I
You're
mean,
right on,
especially
Kimberly.
because you're going to be under all this pressure. So you have to show them the value of investing in your department to help them be more financially, well.
That's right.
And healthy.
That's right. Yeah.
Kimberly, great job today.
Thank you.
It's great to catch up with you. Anything you'd add before we kind of wrap up the interview?
NESHM, the New England Society for Healthcare Materials Management, it's an amazing way to network and build some connections and relationships between you and vendors, as well as between you and other providers and vendors to vendors. So I think it's a really great tool to add to your career and possibly be able to advance your career based on your relationships you have that networking. So find your
networking is so critical. Yeah, I think people underrate the benefits of networking. And, a lot of hospitals don't have budgets to go to send people to the national events anymore. So getting to those local regional events that are cost effective for that and with tightening budgets is also a great way to stay connected to what's on the horizon, from the vendor community, as well as what are other hospitals and organizations, healthcare organizations in your area doing. So Kimberly, great job. Thanks so much for coming on the show.
Thank you, Justin, for having me. And Hayes and Gary, so nice to meet you. Thank you.
We enjoyed it. It was great. Good job. Well done.
Great,
Thank
Kimberly.
you.
Kimberly Alexander, everyone, Director of Materials and Purchasing at Huggins Hospital, and soon to be Director of Purchasing Materials and Value Analysis. Great interview. Hayes, I know you noted that you love the fact that she wears so many different hats at her organization, and it's pretty cool, but it's also pretty cool that in just such a short period of time, she's made such an improvement already and with good things on the horizon.
Yeah, you do have to admire somebody in those roles. They don't have a ton of staff. They don't have all these, fancy technology and scanners and all that. They have to do it the old-fashioned way. And she gets up, goes there, and they've done a really, really good job. And it sounds like she's got some other unique things on the plan. So wonderful job. And again, my hat's off to her for wearing so many hats.
Anybody out there who's working in critical access, especially if you're a little bit newer to your role, I know Kimberly is very involved in ARM, and I'm sure she'd be happy to talk to you as well about some of her successes in her current role. You can find her on LinkedIn. She's active there. Just look up Kimberly Alexander at Huggins Hospital. And on behalf of Gary Hayes and myself, thanks for listening to this episode of Power Supply.
Power Supply.
Thank you for listening to this week's episode of Power Supply. As a reminder, you can help support us by subscribing on your favorite podcast app or by downloading the smartphone app on your iPhone or Android. Simply search for Power Supply in the App Store or Google Play. The best thing about downloading the smartphone app is that you can access bonus content for certain episodes and view episodes in certain categories, like articles on the go and vendor spotlights. Are you following us on LinkedIn or Facebook yet? If you are and you love an episode or post, then let your social network know about it. Like, comment, or share our posts along with your thoughts and keep the conversation going. If you have any topics or guests that you would like to recommend for a future episode, just send us an email to info@powersupplymedia.net. We look forward to hearing from you.